Hello everyone, today we'll be talking about antepartum hemorrhage, to be specific placenta previa. Antepartum hemorrhage is defined as bleeding from the genital tract after 28 weeks gestation to the delivery of the baby. What are the causes? So we have got placental causes, e.g. placental abruptio, placenta previa and vasa previa. Local causes include cervicitis, cervical lesions, carcinoma of cervix, vaginal trauma or vaginitis. And then they can be unknown causes, which is basically idiopathic. So let's talk about placenta previa. Definition. By definition, it's basically just a low-lying placenta. What are the risk factors? Multiple gestation, previous C-section, increasing maternal age, uterine structural anomaly. So how do we grade placenta previa? Type 1. Placenta enroaches on lower segment. Type 2. Placenta reaches internal cervical os. Type 3. Placenta covers cervical os completely but not centrally. Type 4. Placenta covers cervical os completely and centrally. So what is the clinical presentation? So there will be painless pervaginal bleeding. Pervaginal bleeding is usually provoked by coitus. Passage of bright red blood, and there will be no clots. Abdomen will be non-tender, it will be soft, and fetal parts will be palpable. High placenta previa or abnormal lie or malpresentation. Fetal heart is usually present. So how do we manage placenta previa? So the golden rule for antepartum hemorrhage is no vaginal examination should be performed until placenta previa has been excluded. Please take note. So what is the immediate management of placenta previa? Admit the patient, call for help. You need to establish IV access, cross-match blood, hemoglobin check, bedside clotting test. Then you assess the vitals. If shock is present, manage shock. Then the subsequent management of placenta previa include this active management and conservative management. So when do we do active management? If the heavy bleeding continues, if there is fetal compromise, if placenta previa is at term, active management entails delivery of the woman invariably by C-section and resuscitation of the mother if there is maternal compromise. Then what comprises conservative management? If the gestation age is less than 37 completed weeks, if there is no fetal or maternal compromise, if there is minimal PV bleeding or bleeding has stopped. So what is involved in conservative management? Fetal monitoring, you do a kick chart, auscultation, corticotocograph, ultrasound scan. Maternal monitoring, i.e. vitals, you need to count the number of pets that the mother is using. So when should you abandon conservative management? When the gestation reaches term, when there is onset of profuse pervaginal bleeding, when there is fetal compromise, and delivery will invariably be by C-section. Watch out for postpartum hemorrhage. So concept of EIT, it's done under double setup in theater. High doubtful cases of placenta previa at term with cephalic presentation. So what is the conclusion? Antepartum hemorrhage must always be taken seriously. Placental causes are obviously the most worrying. In majority of cases, cause is unknown. So that's all about placenta previa. If you like the video, please like, comment, subscribe. Thank you.